Hello, and welcome to this OncLive peer exchange titled Multiple Myeloma, Planning a Continuum of Care in 2020. I'm Dr. Keith Stewart from University Health Network and Princess Margaret Hospital in Toronto, Canada. Joining me today in this discussion are my colleagues, Dr. Natalie Callender from the University of Wisconsin School of Medicine and Public Health in Madison, Wisconsin, Dr. Tom Martin from the University of California, San Francisco, Helen Diller Family Comprehensive Cancer Center in San Francisco, California, Dr. Nupur Raj from Massachusetts General Hospital in Boston, Massachusetts, and Dr. Peter Voorhees from Atrium Health in Charlotte, North Carolina. Today, we are going to discuss the state-of-the-art treatments for patients with newly diagnosed and relapsed refractory multiple myeloma, including promising agents in the pipeline. We'll discuss the latest research in the field, including from the ASCO 2020 meeting that just passed, and the impact of recent clinical trials on making decisions around treatment selection. So welcome everybody to the Zoom call here, and let's get started on our first topic. We're going to start by covering newly diagnosed myeloma. And I'd like to start perhaps with you, Dr. Raj, and just ask you, what are you using for the treatment of your newly diagnosed patient today? And particularly whether and why you have stuck with that regimen if it hasn't changed recently.
Thanks so much, Keith. It's great to be on this Zoom call. We're doing everything differently now in this COVID era, but hopefully this is all going to work out. As far as newly diagnosed myeloma, I think over the last few years now, most of us are using combinations. So I am using combinations as well. And I think the jury's out. In fact, and most of us are supporting the use of a triplet combination now. You will discuss data later on, but typically most of us, or at least I do, tend to use the combination of lenalidomide with bortezomib and dexamethasone or RVD in the majority of patients with newly diagnosed myeloma.
Tom Martin, what are you using nowadays?
Yeah, I agree that for the majority of patients, we have started triplet-based regimens. My personal preference is actually KRD in patients that are less than age 65 or have high-risk cytogenetics. I think for the rest of the patients, and we'll talk more about data, I think the rest of the patients probably RVD is an excellent regimen for them. So for me, it's a little of both, actually.
And there was at the ASCO meeting a pretty important randomized controlled trial in the plenary session. And I don't know if Natalie, you want to, this is called the Endurance Clinical Trial. Just for our audience, would you like to sort of summarize what that trial was about and what we learned?
So this is really, I think, one of the largest trials that has ever been, largest randomized phase 3 trials that ever has been conducted in the US. And the purpose was to take patients who are newly diagnosed, did not meet a definition of high risk, and were willing to postpone transplant or potentially were transplant ineligible. And so patients, so they did allow patients who had a translocation of 414, but usually the other high-risk features were excluded. And then patients were randomized to receive either 9 cycles of KRD or not 12 cycles of VRD, so the dosing would match. And the hypothesis was that there would be an improvement in PFS in patients receiving KRD. There's a second question that hasn't been reported out yet about length of maintenance with the randomization for 2 years versus indefinite. And then the results are stratified by an intent to transplant at progression. So I think somewhat surprisingly for some people that the results really showed that in terms of progression-free survival, there was not an advantage for KRD. That if you look at all the groups together, they both actually performed pretty well, around in the mid 80%. There were a couple of differences that were striking in the sense that discontinuation in terms of completion of all planned therapy or all planned cycles of VRD was only about 47%, whereas KRD had some slightly higher at 52%. But at the end of the day, there really wasn't a difference. There was a trend towards improvement in PFS for patients who had stage 3 disease, but you know, or higher risk cytogenetics, obviously that's a very small group, but at the end of the day, there really wasn't any difference at all in PFS. And I think the conclusion that a lot of people are drawing from this is that VRD certainly remains the standard in this group of patients. Certainly, I think there's been some talk about this. I'd be very interested to see what the other panelists think about this data.
Well, let's find out. So, Peter, we haven't heard from you yet, Dr. Voorhees. So, what do you think of this? How do you interpret it?
So, this actually is not overly surprising from my perspective. There was a similar study in newly diagnosed transplant-ineligible patients that used bortezomib, melphalan, and prednisone versus carfilzomib, melphalan, and prednisone, and it was similarly designed, where treatment with the regimen was given for a defined duration of time. And in that study, there was also no difference in response rate. There was no difference in progression-free or overall survival. So I think the difference between the Endeavor trial and the relapse setting, and then the carfilzomib versus bortezomib-based regimens in the frontline setting, is that with Endeavor, patients were allowed to stay on therapy until disease progression. And because of the lack of neuropathy signal with carfilzomib, patients can stay on it longer. Whereas in the frontline setting, if you're giving it for a defined duration of time, whether you're using bortezomib or carfilzomib, really doesn't make that much of a difference from an efficacy perspective. And I think that the discussion with the patient has to rest largely on the toxicity profiles between the two different regimens. Whereas with VRD, you're going to see more peripheral neuropathy, which was clearly shown in the endurance trial. You're going to see more vascular toxicity as far as renovascular toxicity, cardiovascular and pulmonary toxicity with the carfilzomib-based strategy. I still, going to what Tom was saying earlier, I like to use KRD in high-risk patients, but I use it in the same manner that it was done in the phase 2 MMRC trial, where the KRD was really implemented in a very Arkinsonian total therapy type manner. And I think how you use the triplet matters more than which of the proteasome inhibitors are part of the regimen.